What we do here matters, because what we don't do matters even more.
We need to continue to push, and we at ADAO are going to continue to push the Surgeon General of the United States.
As you know, the United States continues to use asbestos, and that indeed is a barrier to others stopping its use.
The most horrific part of this whole story is that it is preventable.
All right, so I'll go ahead and start. I'd like to thank the ADAO for inviting me here today to talk about medical monitoring for asbestos-related diseases. And I'd like to start by saying that medical monitoring is really a hybrid term. It includes both medical screening and also medical surveillance. The Encarta, oh, good. Okay, so it includes both medical screening and medical surveillance. The Encarta World English Dictionary defines medical screening as a test or testing carried out on people who are healthy in order to establish as early as possible whether illness or disease exists so that secondary preventive efforts can be undertaken. Medical surveillance, on the other hand, is continual observation of a person or group. So what is the difference between medical screening and medical surveillance? Well, medical screening can be conducted at a single point in time, whereas medical surveillance implicitly is a program of examinations that occur at intervals over a protracted period of time. Now, is this a distinction without a difference? I think in theory, no. I think they are different types of examinations. But in actual practice, I think medical screening and medical surveillance are used interchangeably. The diagnosis of disease, on the other hand, is different than medical screening or medical surveillance. Encarta defines diagnosis as the identification of an illness or disorder in a patient through an interview, physical examination, and medical tests or other procedures, and diagnosis of disease is generally accomplished using the methodology of differential diagnosis. Can medical screening establish a diagnosis? Well, it depends on the outcome of interest, and it also depends on the context in which the screening is taking place. In a medical context, no, with the possible exception of pleural plaques. Diagnosis of disease cannot be made on the basis of information obtained through a medical screening. In the legal context, it has been the case in the past that for you attorneys in the audience, you wish. It would be a lot easier if you could go out, do a medical screening, or carry on a medical surveillance program and make diagnosis of disease. It makes the distance from the examining room to the courthouse a lot shorter. Goals of medical screening for asbestos-related disease are to detect signs of disease as early as possible so that diagnostic studies and preventive measures can be undertaken. Goals of screening for asbestos-related disease in populations were set forth in the Helsinki criteria, which were published in the Scandinavian Journal of Work and Environmental Health in 1997. These goals are the identification of groups at high risk for asbestos-related disease, the targeting of preventive efforts, critically important, the discovery of new occupational disease, and improvement in the treatment and rehabilitation of those who have asbestos-related disease, and prevention of additional related adverse health outcomes. The target population determines how useful a screening is. High-risk target populations result in more productive screening examinations. For asbestos-related disease, risk is determined on the basis of intensity and duration of asbestos exposure, and also on latency. There are other occupational lung diseases for which this is not true. An example is pulmonary beryllium disease, which is a hypersensitivity or a sensitization phenomenon, so that intensity, duration, and latency are less predictable of occurrence of disease in an exposed population. There is variability from individual to individual. The disease outcome determines the nature of the screen, and it differs depending on whether you're talking about non-malignant disease or malignant disease. Non-malignant asbestos-related diseases, as everybody in this room knows, include asbestosis, pleural plaques, and diffuse pleural thickening. Malignant diseases, as you have heard, include lung cancer, malignant mesothelioma, cancer of the larynx, and cancer of the ovary. For purposes of this discussion, I'm going to focus on lung cancer and malignant mesothelioma. In 2000, the Association of Occupational and Environmental Clinics in Washington published appropriate screening criteria. The criteria include, for non-malignant asbestos-related disease, this is non-malignant disease, and it includes a chest x-ray reviewed within 1 week of the examination and properly interpreted, not necessarily by a B reader, but certainly by an experienced A reader or an experienced chest radiologist. Comprehensive exposure history, review of symptoms and systems, spirometry that meets criteria for standardization, and physical examination. In 2002, NIOSH added, it should be self-apparent, but they added that the screening should be carried out by a knowledgeable physician or other healthcare provider. Now, medical screening is a good thing, right? Is there anybody in the audience that thinks medical screening is not a good thing? It's like the American flag. I don't see any hands. Well, it's not necessarily a good thing. It depends on how it's carried out. The AOEC had concerns, and their general concerns were that medically inadequate screenings were being carried out, that these inadequate screenings were being carried out in the context of legal action rather than in the context of appropriate health care and education of those individuals who were being screened, so that sometimes less is more. Specific concerns were that brief and or non-standardized questionnaires were being used to obtain exposure and medical history, that there was reliance on chest x-rays and spirometry that were not necessarily standardized and of variable quality, that interpretation was biased either in favor of the attorney who did or did not want to find disease, or in some cases if the screening or surveillance was being carried out by a company, there would be an obvious bias against finding disease in most cases. And importantly, that diagnosis was based on insufficient data. Diagnoses of asbestosis were being made on the basis of chest x-ray alone. That follow-up was inadequate. There was failure to communicate findings clearly to those who participated, and there are examples. There was an article that was published by Dr. David Eagleman in which an individual committed suicide because he did not understand what he was being told about the findings at the time of a medical screening. Failure to assure proper follow-up of abnormalities that are detected, for example, a lesion on a chest x-ray that could be lung cancer, gets overlooked and not followed up on. And then lack of attention to education and prevention. No education about smoking cessation in asbestos-exposed people who were already at high risk for lung cancer. Now, I'd like to turn to malignant asbestos-related diseases and talk about screening modalities for lung cancer and malignant mesothelioma. Historically, sputum cytology and chest x-ray, it's not that they have been used, but they have been investigated as screening modalities for lung cancer and found to be lacking. Other potential modalities for screening for lung cancer are, and I say potential, are conventional chest CT scan and low-dose chest CT scan. survival in the case of lung cancer depends very much on the stage of the cancer at the time it is detected. The best stage is stage 1A, which means that the lesion is less than 3 centimeters in diameter and there's no metastatic disease to lymph nodes or distal organs. And just to review, oops, sorry, I thought this, one of the side effects of screenings, and there are side effects of screenings, in the case of using radiology or tomography to screen for lung cancer is, actually, I'm one slide ahead. So chest x-rays have been found to detect cancers early, that is when they're stage 1A, 25% of the time. So not great, but better than usual clinical care, which detects lung cancers when they're stage 1A only 16% of the time. Low-dose chest CT scan screening has been found to detect early lung cancers that are potentially curable 55 to 85% of the time at baseline and 60 to 100% on follow-up or interim CT scans. So low-dose chest CT screening in a number of studies has been shown to be much more effective than usual clinical care or chest x-ray. Now, one of the side effects of using chest x-rays or CT scans to screen for lung cancer is that there is radiation exposure. Just to give you some comparison data, chest x-ray delivers 0.1 millisieverts of radiation to the individual. Conventional chest CT scan delivers 80 times that amount, or 8 millisieverts, whereas low-dose chest CT scan delivers a dose of radiation that is greater than chest x-ray, but much less than conventional chest CT scan, ranges from 0.1 to 1.5 millisieverts, depending on where it's done and who's doing it. In October of 2006, a study was published in the New England Journal of Medicine that presented the results of a study, a large study of individuals at risk for lung cancer. And the study looked at survival of patients with stage 1 lung cancer who had undergone low-dose chest CT screening. And this was sort of a shot across the bow and ignited a controversy among scientific investigators and physicians regarding the use of low-dose chest CT scan to screen for lung cancer. The International Early Lung Cancer Action Project was the group that conducted the study, and it's an ongoing study. They screened over 30,000 individuals at increased risk for lung cancer as a result of age, smoking habits, and occupational exposure to asbestos, beryllium, and uranium. In this study, 484 cancers were detected, 85% were stage 1. Of these 484 cancers, 302, or 62%, were resected within 1 month. Oh, I'm sorry, that's not better. You'll just have to take my word for it. The investigators looked at, they estimated 10-year survival in this population. And what they found was that the group who was stage 1A when the cancer was detected, who had undergone resection, had an estimated 92% 10-year survival, which is, it was based on small numbers, but nevertheless, that's a rather dramatic improvement in survival. For those who were stage 1A but did not undergo resection, survival was 85%, and for all comers, it was 80%. So it indicated that screening with low-dose chest CT scan in at-risk populations improved survival in those with lung cancer. Now, critics said, well, maybe it improved survival, but it didn't have any effect on mortality. The NIOSH conducted a randomized controlled trial looking at mortality from lung cancer with low-dose chest CT screening. The study was stopped early because the question was answered, and the results were published, if not initially, very close to initially, by the Wall Street Journal. And I'm about to run out of time here. It was the NLST, and people were randomly assigned either to low-dose CT scan or chest x-ray for screening, followed for 5 years beyond. there was a 20% drop in lung cancer mortality in those screened with LDCT, and a 6.7% drop in overall and all-cause mortality for reasons not entirely clear. And gradually, the groups have begun to recommend low-dose chest CT screening for those with lung cancer, including the ALA, American Lung Association, and the National Comprehensive Cancer Network. I'm about to run out of time. Screening for malignant mesothelioma has not proven to be worthwhile, and 2 biomarkers have been looked at, soluble mesothelium-related protein and osteopontin. Neither has been shown to be effective as a screening tool for malignant mesothelioma, and I'm sorry I've run out of time. I'll be happy to answer any questions at the end of the session here. Thank you very much.